Okay.
The broadcast is now starting. All attendees are in listen-only mode.
Hello, I'm Catherine Poole, President and founder of the Melanoma International Foundation, and I want to welcome all of you to our webinar tonight. I believe we can all say that we're finally on the right road to finding an effective therapy for melanoma. The science can't do it alone, however. All of you who came here to learn more to fight your disease or that of a loved one are to be congratulated. Without patient involvement, research can go nowhere. So you're a very important part of the whole science. To learn more about targeted therapies, it's our pleasure tonight to present two of our scientific board members, Keith Flaherty and Gary Schwartz, who are both leading researchers in the field. After the presentations, please stay tuned as both Dr. Flaherty and Dr. Schwartz will be answering your wonderful questions that you have sent in to us. Okay, so first we're going to get moving with Dr. Gary Schwartz. He is the Chief of the Melanoma Sarcoma Service at Memorial Sloan Kettering.
Good evening, everybody, and Catherine, thank you for that nice introduction. I think we'll go to the first slide. And I do welcome everybody to the webinar. I hope this will be an educational session for everybody involved. The way we're setting up the session this evening is I'll be discussing some of the less common forms of melanoma where there's rather less frequent mutations, such as the KIT oncogene. I'll also discuss briefly some of the ocular melanoma work that's ongoing as part of national trials, and that'll segue into Dr. Flaherty's presentation on the BRAF program and how that's now having such a major impact upon cancer care and melanoma. And then, as Catherine said, we'll then follow that up with a question-and-answer period. We have received some questions already. We'll address those, and hopefully it'll be an interesting and dynamic session using this new technology, the webinar. So in the first slide shows some of the pathways that are activated in melanoma. Most of our focus, of course, is on BRAF, but in melanoma, of course, we have mutations in NRAS and BRAF, and these lead to activation of the MEK and the ERK pathway. Next slide, please. So when we speak of melanoma, we really need to focus on the complexity of this cancer, and addresses the current way that drugs are being developed in the field. In this slide, we show you of course, different manifestations of melanoma in terms of where it can arise from. We have melanomas which are the predominant type that arise from the skin, where in fact there is not a chronic sun damage. This is the type of melanoma that is secondary to sunburns. Many of us have had, of course, when we were very young, and with repeated acute sun damage over time, this leads to a certain type of melanoma. That's actually molecularly distinct from those which come from chronic sun damage. These are the melanomas that we see in parts of the world where there is chronic sun exposure. The southern part of the United States, where people are in the sun all the time. Parts of Australia where people are working outside all the time. And in fact, there's a different biological entity from that, and we'll talk about that briefly. Thirdly, there are melanomas that arise from mucosal surfaces. These can come from the oral pharynx, the inner part of the mouth. They can come from the GI tract, the nasal sinuses, really areas for which there is no sun exposure, but interestingly enough, patients still do get melanoma even though there's no sun exposure to those sites. And finally, there are melanomas that come from the bottom of the feet and the palms of the hand. We call those acral melanomas. Again, areas where we don't have much sun exposure, but clearly there are melanomas that can arise from these areas. But if we look at the biology and the molecular basis of these tumors, can we go forward, please? we see that there clearly our molecular basis is quite different from one tumor type to the next. We talk about tumors from which there are, from the sun-exposed chronic sun damage, we see in fact in these tumor types, the predominant tumor type with those from which is sunburned skin, 60% of these tumors will have a mutation in the BRAF gene. This in contrast to tumors which have chronic sun damage, in which only 10% will have a BRAF mutation, but 28% in fact will have mutation of another oncogene called KIT, which is another driver for melanogenesis, and which is common in 28% of these tumors, from which there is chronic sun damage, in contrast from which there is acute sun damage. And lastly, there are these two other tumor types which we've been talking about, the mucosal melanomas and the acral melanomas. Again, there can be BRAF mutations, but maybe in the order of 10 to 20%. But in these other areas where there clearly is no sun exposure, the most common mutation is in the c-KIT gene in the order of about 35 to 40%. So clearly the melanomas that we see, though under the microscope they look quite similar. They'll have melanin, they're all dark and pigmented as shown in the slide here, but the basic molecular biology is quite different from tumor type to tumor type. But this does lead to opportunities for drug development, such that tumors that are BRAF mutant will be most susceptible to BRAF inhibitors. For those tumors that are c-KIT mutant, in fact, will be most susceptible to c-KIT inhibitors. And this is the way drugs are being developed currently in the field of melanoma. And we'll now present some of the data showing how this will be applied. Next slide, please. So the first attempt to look at the c-KIT field was with imatinib therapy, and the drug is shown here. Imatinib is a structure, it's a small molecule, it's an orally administered drug. It targets another number of targets, including c-KIT, but also has effects on BCR-ABL, when in fact it was first tested in certain types of leukemia, such as CML, where it's quite effective in targeting that translocation oncoprotein. Also has activity, though, in the PGFR family members as well. Next slide, please. So the understanding of KIT actually came from a very early observation published by Jose Lutsky and Boris Bastian, and followed by other papers in the Journal of Clinical Oncology. And there are a couple of anecdotes here just to show some of the responses that have been observed using imatinib in patients who have these types of mucosal melanomas. That is, the melanomas that don't arise on the acute sunburn areas, but arise in these more difficult areas, such as the pharynx, the mouth, the nasal sinuses, or the anal canal. And all these tumors are characterized by either mutation in KIT or amplification of the KIT oncogene. All these patients were started on imatinib therapy, and all of them had a metastatic disease, and all of them had quite dramatic clinical benefits to imatinib at rather modest doses of 400 milligrams per day, which is a well-tolerated dose, and is the dose that's approved, in fact, for the treatment of a more common tumor called GIST, which we see in sarcomas. In fact, that was the first tumor type in solid tumors where imatinib was shown to be an effective therapy with excellent tolerance and good durability. Patients can stay on imatinib with the sarcomas for years who have mutations in this KIT oncogene. Here is a PET scan published in Journal of Clinical Oncology. This is from the paper, I believe, by Steve Hody, showing a rather dramatic response by PET to imatinib therapy. Next slide, please. So based on these responses that are anecdotal, again, rare responses on a case-by-case basis, we actually have just completed a phase 2 trial testing imatinib in patients who have KIT mutant melanoma. For these studies, we sequenced all patients' tumors for KIT. Dr. Bastian, in fact, did the sequencing when he was at the University of California, San Francisco. He's actually now moved to Memorial Sloan Kettering as our chief of pathology. The FISH for amplification is done by Christine Antonescu, who's done a lot of this work in the GIST patients. And all patients are required to have either a KIT mutation or the amplification. I should add that when imatinib was studied in non-selected patients, that is, in patients who did not have KIT mutational analysis done. In earlier trials, there was only one responder in 60 patients, and that one patient, in fact, had the KIT mutation. All the other 59 patients did not. So we really do believe, based on data, that this is going to be a very important tool to determine who will benefit from this drug. And without this mutation, I would argue that you will not respond to this class of agents. In the study, we selected to go to the higher doses of 400 milligrams PO twice a day of the drug rather than the lower 400 milligram a day dose. Though frankly, we don't know if that'll make a difference, and I suspect twice a daily dosing will be eventually proven to be as good as once daily dosing, as has been shown to be the effects in, again, that sarcoma we call GIST, where this drug is already approved for the treatment of c-KIT mutant GIST sarcomas. Next slide, please. Eligibility, again, was from tumors of the acral mucosa or chronic sun-damaged skin. Tumors had to have the KIT amplification or the mutation. They could not have had prior KIT therapy, targeted therapy, and the generally other standard criteria were used for study eligibility. Next slide, please. So I'm just going to show, again, a few anecdotes. We're still analyzing data, but just to show you just how unbelievably active this drug can be in patients who have acral melanoma or other types of melanomas where there are KIT mutations. This is an 88-year-old woman who had an exon 11 mutation, and she had advanced acral melanoma, came from between the digits of her toes, and now she had in-transit metastases to other soft tissue sites. She'd failed really all other therapies, Oncovex, which I think was one of the questions. She was on an Oncovex trial, topical Imatinib, and she had this exon 11 mutation, quite classic for the KIT oncogene as a driver for formation of these tumors. Next slide, please. So here's the data. This is the PET imaging before she started in studies, and all those little black spots there are PET-positive melanomas. You can see actually the recurrence of the primary in the lower part of the left foot. That little black dot is the very between the two toes on the foot, and you can see all the lesions that are rising that are metastasized to the soft tissues. And then after just almost a little over a month of therapy, she has this repeat PET scan, and now you see that essentially all the lesions are gone. And now 2 months later, she's in basically complete remission. We actually biopsied her tumor and found really no residual melanoma present. And this woman continues to be on study at this point. Next slide, please. This is just the pathology. So just in terms of the overall field of melanoma, I don't want to dwell on all the responses we're seeing in the field, and I'm going to reserve the final response data, but to tell you the truth, it's quite active. We're very encouraged by the data, and there are other centers now conducting comparable studies to answer the question, how good is Imatinib in the treatment of melanoma? But it's not just Imatinib. In fact, there are many other drugs that are similar to Imatinib that are being tested in patients with these types of c-KIT mutant melanoma. This is a summary slide addressing all the active or recently completed clinical trials testing KIT inhibitors in these types of c-KIT mutant melanoma, including a drug called Malignancy, which we'll come back to shortly. There's also a study on Sunitinib, another KIT inhibitor. It's a tyrosine kinase inhibitor. It also inhibits PDGF and some other targets. But I just wanted to give you a sense of how this field is evolving. There's a study of Dasatinib being conducted by Dr. Lawrence at Mass General. Again, another Sunitinib study being done by Dr. Hody at the Dana-Farber, and combinations of chemotherapy such as Dasatinib and chemotherapy being done by Dr. Dowd at University of California, San Francisco. So the field is ongoing, and we're going to be hearing more and more about these studies as the data becomes available. Next slide, please. So one of the ongoing plans, and it's based on our Imatinib data, Novartis is pursuing a second-generation drug called Tasigna or Nilotinib. It was mentioned on the other slide. And this will be a randomized phase 3 trial in which there will be a comparison of Nilotinib to dacarbazine in the treatments with metastatic c-KIT mutant melanoma, or those of inoperable disease. All patients will have to harbor a c-KIT mutation. Will have to have the common mutations in exon 11, 13, or 17. It's going to be a 120-patient randomized study, and patients who are randomized to dacarbazine as the first therapy will be allowed to take nilotinib should they progress on chemotherapy. The primary endpoint here will be progression-free survival, not overall survival, and therefore patients who get the chemotherapy will still be provided access to nilotinib at the point at which the chemotherapy is shown to be ineffective. Next slide, please. Now, why nilotinib? Nilotinib is active against the CTEP mutant melanoma cells. In fact, when compared to imatinib, it may be more active, at least in cell culture. It's shown to be clinically active in GIST patients who are resistant to both imatinib and sunitinib. Remember, GIST is the sarcoma equivalent to the CTEP mutant melanoma, which was the first tumor type to be shown for which this drug was shown to be active, and at least there's some clinical data suggesting nilotinib may be more effective. In culture, in cell culture, nilotinib goes into the cells better. There's data generated by Novartis showing if you look at intracellular concentrations of a nilotinib, they're higher than those of imatinib, suggesting that nilotinib may have a better penetration into the tumor cells. There may be less toxicities with nilotinib, also called tosigna, especially on the GI tract. There's little fluid retention with nilotinib. Patients on imatinib complain of edema, especially of their legs and around their face, called periorbital edema, and at least the nilotinib seems to have less side effects. Also, there's been recently completed trial in CML where nilotinib was compared to imatinib in a head-to-head trial. Remember, CML is where the other oncogene BCR-ABL is expressed, and imatinib is highly, highly active in that disease. But in a recent randomized trial, nilotinib was shown to be superior to imatinib. So based on this, nilotinib may be a better drug, and that is the reason why the randomized trial with dacarbazine is testing nilotinib, not imatinib, versus chemotherapy. And this is the drug that Novartis hopes will eventually be registered for the treatment of patients with acral, mucosal, or chronic sun-damaged skin melanoma that have the CTEP mutation. Next slide, please. Again, this is just more information about the study. Open study, randomized trial, nilotinib versus dacarbazine, which will be given every 3 weeks. Nilotinib will be given twice daily at a dose of 400 milligrams. Randomization will be 1-to-1, and there'll be a central review for determining randomization. It's going to be a large study. 83 sites in over 15 countries will be participating. It'll be the largest worldwide study ever in this type of melanoma, and we hope that anybody who has this disease will participate in the clinical trial. Next slide, please. Again, more about the randomization. Next slide, please. Just more about eligibility. I think I've addressed this already about histological confirmation, have to have the mutation, unresectability, and there has to be also measurable disease. Next slide, please. So I want to, before shifting to the BRAF mutant melanoma, I just want to talk about the uveal melanomas and some of the progress being made in this field. Again, it's a very rare disease. Uveal melanoma is the most common primary intraocular melanoma in adults. It arises from melanocytes within the choroid plexus and accounts for 70% of all eye malignancies. And despite adequate treatment of the primary lesion, which often involves radiation or even surgery, 50% of patients with these types of melanomas arising in the eye will develop metastatic disease within 15 years of initial diagnosis and initial treatment treatment. So this is a highly resistant tumor type to therapy. I just lost my slides. Hold on a second. That back on. So it's a highly resistant treatment to chemotherapy. In fact, there are no effective therapies in this particular disease. And if there is a therapy, it really works very long. Next slide, please. So this is a slide just showing the pathways that may be appropriate for targeting in this type of melanoma. And what I'm showing you here is that one of the common phenotypes, can you just go one more forward, please, is that unlike the cutaneous melanomas where there are BRAF mutations, next forward, These cells have mutations in a protein called the G protein. This is called the GNAQ protein, and actually recently there's been a secondary protein discovered called GNA11. Both of these are from the G protein family members. Mutations of this pathway lead to activation of downstream signaling events, and most remarkably, they activate the MEK-MAP kinase pathway. Now, this is not activation through the BRAF system, which we see in the cutaneous melanomas, and actually melanomas arising from the iris, a very rare form of this. But this activation is driven through the GNAQ, GNA11 pathway. This has been reported by Boris Bastian, and seems to present to us another target for that of an ocular melanoma, is can we target the MAP kinase pathway with MEK inhibitors similar to what's being tested in cutaneous melanoma with BRAF or MEK inhibitors. Next slide, please. So this is data we presented at this year's American Association of Cancer Research meeting from my laboratory. It's not been fully published yet, but is part of public domain. And it illustrates the effects of a drug called AZD6244. This is a drug that inhibits the MEK pathway. And what I'm showing you here is the growth of cells in either the presence or absence of this drug. In particular, what we're showing you, actually the legend is not correct. This is all cell lines that have been treated just with the AZD6244 based on different molecular backgrounds. And what it's showing you here is increasing concentrations of the drug, such that at the highest concentrations of the drug, which is the far right blue bar, there is dramatic inhibition of these cell lines in nanomolar concentrations of the drug. And this drug is particularly effective in tumors that have the GNAQ mutation. So if you look at the wild-type cells on the far left, these cells show a relative resistance to increasing concentrations of AZD6244. But if you go to the very far right, which is the highest concentration of the drug, that is the highest concentration of AZD6244, there's quite a significant inhibition of cell growth. And this correlates quite nicely to the inhibition of the downstream signal phospho-ERK, which reflects the inhibition of the target by AZD6244. So if you take a cell in which there's essentially no mutation and give this drug as a single agent, we see essentially no inhibition of growth. But if you have cell lines in which there is either a BRAF mutation or a GNAQ mutation and give them higher concentrations of the drug, especially in low concentrations, we now see marked inhibition of cell growth, and that is consistent with the inhibition of the target phospho-ERK, which is the known MEK downstream signal event. So next slide. So based on this data and other data we've generated indicating that these cells are highly sensitive to MEK inhibition, we have been approved for a clinical trial in which patients with metastatic uveal melanoma will either be treated with AZD6244 or temozolomide. At time of progression, patients who get temozolomide can then be crossed over to AZD6244. Therefore, all patients who have a mutation in this pathway will be eligible for the drug. In addition, we're also accepting patients into the trial who have had either temozolomide or dacarbazine at other sites, and they will also be eligible for 6244 as a single agent and not have to go into the randomization. But this will be the first national trial ever testing a MEK inhibitor in patients with this type of melanoma, comparing chemotherapy to a MEK inhibitor, either as first-line therapy or second-line therapy. All patients will be tested for mutational status at time of presentation, though mutational status will not be required to participate in the trial. Next slide, please. So these are the cohorts we'll be treating in the clinical trial. There's the major patient population with those who've had no prior chemotherapy. They will either have a GNA11 or a GNAQ mutation, and there'll be the randomization either temozolomide or to AZD6244. In addition, there'll be a second cohort, again, who've had no prior chemotherapy. we will allow at least a limited patient population who have wild-type GNAQ or GNA11. By that I mean the patients, though infrequent, who have neither of these mutations. We think based on our current data, about 80% of patients with ocular melanomas will have either the GNA11 or the GNAQ mutation. And finally, there will be a third cohort who have had prior chemotherapy that have been treated with chemotherapy previously. These patients will have to have a mutation, and they will be all administered and allowed to enter the trial for single-agent MEK-targeted therapy with AZD6244. This study is just open. We've just treated now 5 patients who are being actively treated on different parts of the trial. And if there's a patient on the call, or if you know of a patient who has this disease, we'd be delighted to see them at our center or the other cancer centers that are participating in the clinical trial. There'll be open sites in Boston, New York, and different sites across the country, and will be the largest national study ever to test this disease with a targeted therapy of the MEK pathway. Next slide. So in conclusions for this part of the study, I think genetics of melanoma are providing new opportunities, new identification. We have now drugs that target CTEP and BRAF, and Dr. Flaherty is going to talk a little bit about that. I think there are issues that we'll need to address in terms of drug resistance, and that will come up in the next half of the talk. But I think we're now making great progress in identifying targets, and as we identify these targets, there are new opportunities for cancer therapeutics, and we already see evidence, and I think I've shown you a little bit about that, especially with the acral melanoma patients, where there are benefits to patients in melanoma that weren't really seen before, with drugs that have minimal toxicities but clearly can be beneficial, especially if we find the right drug for the right patient based on the molecular biology of the cancer. Next slide, please. So now I'm going to introduce Dr. Flaherty. Dr. Flaherty is going to talk about, I think, an area that we're all interested in, greatly interested in. This is the area of BRAF targeting. We've seen great drug development in this area over the last 6 months. Dr. Flaherty, in fact, published the seminal paper on this in New England Journal of Medicine just a month or 2 ago. Dr. Flaherty is the Director of Development of Therapeutics at Mass General Hospital. And now I open the line to Dr. Flaherty. The line is all yours.
Great. Thank you, Gary. So again, welcome to everyone, and thank you for joining this discussion this evening. We'll try to save plenty of time for questions and answers. So for that, with that in mind, I'm going to jump right in and really pick up where Dr. Schwartz left off. He gave really the foundation, upon which all my comments are built, which is essentially the idea that the key leverage point, we think, for advances that we're observing right now in the clinic with new drugs that are clearly benefiting patients, as well as where we think the gains will be made in the next several years and beyond, really stem from the genetic understanding of this disease. And by genetic, I don't mean the genetic alterations or the genetic predisposition, if you will, to getting melanoma, but rather the genetic changes or mutations, as we call them, that happen inside a melanoma cell to allow it to become melanoma in the first place. It's understanding, that idea of sort of what it is that makes a melanoma tick that has really given us, a foothold in terms of trying to come up with drug strategies to counter that directly. And yet, I think we're very much in the early stages. So many of my comments, I'll try to amplify that point. If I can just click, stay on this slide, but just click once to advance. I think we'll get, there we go. So as we've discussed so far, basically this central pathway, as we call it, that connects the surface of a cell into the brains of the operation, the nucleus, this is a pathway which we refer to as the MEK-ERK pathway or the MAP kinase pathway, all sorts of jargon around this so-called bucket brigade of molecules that communicate from one to another. But it's the discovery that at the top of this pathway, the squiggly line, if you will, I think I've got the mouse here. This so-called c-KIT receptor, we think, is probably one of the more important ones in terms of melanoma. And as Dr. Schwartz just indicated to you, it's that receptor that has mutations in a subset of melanoma tumors. And then when we identify that, then we very much focus our attention there. NRAS sits just below that, if you will, and that can have mutations as well. I'm going to come back to that actually in a little bit. But then further down in this cascade of signaling molecules are the RAF kinases, as they're called, BRAF and CRAF. Now, it turns out CRAF is not an enzyme that has mutations in it, not only in melanoma, but really any other cancer for that matter. It was in 2002 that we learned about mutations in BRAF, the one highlighted in green there. And when mutations happen in BRAF, basically what it does is it turns this enzyme into the on position. All enzymes have essentially an off and on position, but this mutation basically locks it into the on position. And as a consequence, it doesn't need the input of any of the proteins above it in this pathway. Normally that would be the case, but when a mutation is present, it's basically just acting in an autonomous fashion to then stimulate signaling further down in the pathway. And this pathway that we keep talking about this evening is one of the best studied in cancer, in fact. Well before we ever knew about mutations in enzymes like BRAF, it was known that this pathway is very critical to certainly the growth and proliferation of cancer cells, but it turns out that there's other properties that we attribute to cancer that seem to stem from signaling through this pathway as well. So for that reason alone, when scientists looked and discovered mutations in BRAF, it was very much of a aha moment in the cancer research field, because it really seemed to be somewhat of a missing piece to the puzzle as to why this pathway seems to be so important in cancer. So it turns out about 7 to 8% of all cancers have mutations in BRAF, but in melanoma, as Dr. Schwartz already highlighted, it's about 50%, maybe a little bit more than that, of all cases of melanoma where you'll find one of these mutations. And that then makes it the most commonly mutated enzyme for which we potentially can develop drugs anyway, that's yet been identified. So I have relatively few slides. I'll warn you in advance. I'm not going to be talking quite so long on the topic of the other ones. But basically what the rest of this slide is meant to show you is that we have multiple drugs that have moved forward now, very recently, that are able to block various components of this pathway. And on the left and the right of the slide, you see what I'm referring to here as the so-called selective BRAF inhibitors, and then the less selective drugs, drugs that block both BRAF and CRAF, and in fact some other signaling molecules as well. And it's really on the left-hand side of the slide, PLX4032 and equally GSK2118436, these two pill-based therapies that were designed to block BRAF function and essentially turn off this enzyme that's constantly turned on by mutation. It's these two drugs that have really been the ones that have generated the great excitement, because even in their earliest clinical trials, their so-called phase 1 clinical trials, they've shown that in patients who have metastatic melanoma and a BRAF mutation in their tumor, and just to emphasize that again, specifically in the patients who have a BRAF mutation in their tumor, these drugs have worked, frankly, more reliably in the short to intermediate term than we really had even hoped possible, based on a long series of scientific sort of reasons and hypotheses that we had even after BRAF mutations were discovered. So this has really captured a lot of attention because the commonness of the mutation, about 50% of all melanomas, and the recent results of these two early clinical trials with both of these pill-based therapies. We don't have results yet for a couple of the drugs on the right-hand side. So RAF265 and XL281 are drugs that have also been in early clinical testing, phase 1, and a little bit beyond that now for XL281. But we just haven't yet seen the results of patients with melanoma, particularly those with BRAF mutation, treated with these agents to know how do these compare. Are they as good? Are they potentially better? Are they inferior? We just don't know. One concern that you would have with this concept of targeted therapy in general is that drugs that block more than just your intended target could bring side effects along with them that are undesirable. The flip side, as I'm pointing out on this slide, is that maybe blocking both BRAF and CRAF could be of value, and I'm going to come back to that a little bit later. You see that there's drugs that block this molecule MEK downstream in the pathway, and there have been studies done with each of these drugs in patients who have a BRAF mutation, and it turns out that blocking MEK can actually intercept much of what activated mutated BRAF is trying to do. So there is evidence that these drugs actually, on their own, can contribute in a beneficial way. And really trying to sort out which is the best approach with any of these types of drugs is something that we just don't yet have the information, because we have individual clinical trials with individual drugs so far. If I can have the next slide, please. Thank you. So what I'm going to show you here on this slide and the next slide is just a schematic depiction, if you will, of the patients treated on the PLX4032 phase 1 trial. And these are patients who were treated near the end of the study. So these are patients with metastatic melanoma, all of whom had a BRAF mutation. And basically all of them were receiving the dose that had at that point been determined to be the safe, sort of the highest safe dose, basically, that could be given of this drug. Pill-based therapy taken twice a day, every day. And what I'm showing you here is comparing each patient's tumor volume or tumor burden, if you will, basically comparing the first follow-up scan that they had to their baseline scan. So typically that's about 2 months into therapy that we do scans to try to judge, is someone responding to therapy. And each of these vertical bars represents a patient. So you see the bars that go down from the 0 line are ones who've had shrinkage, and then the bars that go up, unfortunately, are ones who've had evidence of tumor growth at that early point. So this is just early judging of response. And basically, somewhat to our surprise, we saw that across this panel of 32 patients, we saw a rather remarkably uniform direction, if you will, with shrinkage happening in the vast majority of these patients, but notably not all. Now, you'll also notice, of course, that these patients really line up with responses that are in the 20% range, let's say, all the way to the right-hand side, 100% are complete shrinkage of visible tumors, not necessarily eradication of the disease in total, but at least such that we can't see it on the scans. And it's this result, just as I'm showing it and summarizing it here, that really took us almost by surprise. We had hoped for something like this, but I think maybe in some ways it was beyond many people's hopes that we would see this kind of early effect of therapy. Now, if I can have the next slide. Now, we have to immediately sort of caution people not to make too much of that early effect, because as has been seen in other cancers treated with targeted therapies like this, but targeting different molecules that are mutated in other cancers, basically responses that happen in some cases are not as long-lasting as we would like. Now, in some cases, they're quite long-lasting and still ongoing, but there's really quite a spectrum here, and that's what I'm showing you on this slide. So this is the same 32 patients I showed you on the previous slide, but now we're marching out in time, as measured in months, as you can see down below, where basically patients begin therapy at time 0, and then you see them continuing on treatment, unless their tumors got worse at some point. So they could have responded initially, but if there was then growth of tumor after that time, and there's a certain amount of growth that is used in clinical trials to judge, basically what's enough to constitute a reason to potentially stop therapy, that's represented here as a red dot. So you see some patients at the bottom of the slide who never had a response. It's the couple of patients who had growth right away. And then above that, you have patients, and particularly those ones with the gray diamond shapes, who had tumor shrinkage, clear evidence of tumor shrinkage. But then you see in subsequent months, and sometimes only a couple of months, we saw evidence of tumor growth. And obviously that is disappointing in many ways for those individual patients, and as we care for them, really almost sort of wipes out the enthusiasm one might have had for the shrinkage that happened in the beginning. But then towards the top part of the slide, you see the patients who've had a response and are still ongoing now for a number of months. And this is the data as we published it about a month ago. So we're still following these patients, still treating them, of course. And the key question is, well, can we understand beyond just BRAF mutation? Is there something about some of these patients that would tell us that they're going to get long-term benefit from therapy? And by long-term, I mean, let's say perhaps beyond a year, but obviously we're hoping for even longer than that. We do have evidence from actually some patients not shown on this slide that responses can go on 2 years and potentially longer in some individuals. But I just want to emphasize that as frequently as we do see responses, the duration of them really is quite variable. And we believe this is a critical foot in the door, and I think I would emphasize that statement for many patients, but it's quite clear that there's room for improvement in terms of trying to figure out how to do even better. Maybe with next generation BRAF inhibitors, but just the same, I would probably emphasize the idea that maybe where we're going to see the biggest gains is actually in combination approaches. So combining these drugs, BRAF inhibitors, with other drugs potentially in the same pathway, and with drugs that target other molecules and other pathways. So we'll come back to this, of course, in question and answer, but let me just sort of keep moving here. That there continues to be a lot of work beyond just the tumors and the genetic alterations that we've talked about, because so far we've talked about CTEP and GNAQ and GNA11 and BRAF, and yet you put all those together and you're still only just above about 50% of all melanomas that have one of those mutations. So there's clearly domains or territory that we're not covering yet in terms of people with melanoma who have different mutations in their tumors that we don't currently have a successful strategy for. And on this next slide, that's what I'm basically trying to summarize for the tumors that have an NRAS mutation. So as I mentioned briefly before, it turns out about 20% of all melanomas have a mutation in this protein. You won't find a BRAF mutation and an NRAS mutation in the same tumor cell. So basically, if you look at it this way, a melanoma only needs one or the other. So again, a significant subset of melanomas have an NRAS mutation. We've actually known that for more than 20 years. But the problem is that drugs to target NRAS have really not been able to be developed. So there's just a technical problem, if you will, where the enzyme function of NRAS is just simply not something that's amenable to targeting with the types of drugs that we have currently. And that may change in the future. But suffice to say that NRAS goes on to stimulate this pathway in which BRAF, MEK, and ERK sit. But it also does other things, and I've just sort of alluded to that here on the left-hand side of the slide. There's another well-known pathway in cancer that's driven by this molecule PI3 kinase. And it turns out NRAS can turn on that molecule and then activate signaling through that pathway as well. And in fact, there have been other pathways that have been implicated as being, quote-unquote, downstream of NRAS. So the idea here is that if we're going to try to drug NRAS, we're going to try to target it, if you will. We may not have drugs right now that can directly block it, but we do have drugs, and that's what I'm highlighting here on this slide, that can block some of these molecules that NRAS is activating. And actually, that's going to be the work of the next few months and year or so, where combinations actually have been put together of drugs in each pathway, aiming to try to treat RAS mutant cancers. And so this is very much of a work in progress, and as it applies to melanoma, we really just don't even have any experience yet or data yet to point to. So if I can have the next slide. Just to highlight a key point before we sort of wrap up and jump into questions and answers, here on this slide I'm just sort of highlighting the fact that there are melanomas that have mutations in none of these things. So don't have mutations in CTEP, GNAQ, GNA11, BRAF, or even NRAS. And there, we know that other mutations can exist, but unfortunately some of those are not ones that can be targeted with drugs. And we really have more work to do. And so this is where there's the full spectrum of research ongoing right now. Yes, drug trials against sort of targets that we've identified, as we've talked about tonight, are key, and we're enthusiastic and excited about developments there. But we still have a lot of work to do actually in the laboratory, even to try to decode melanoma further to understand what the right set of targets will be ultimately for all cases of melanoma, not just these ones that we've been able to discover thus far. So there's a bit of work still to be done to try to apply this type of approach to all of melanoma, but we're sort of, if you will, biting off pieces of the pie as we go in terms of trying to understand what the genetic makeup of this cancer is. I think that's my last slide. You can maybe just advance. Yep, we're there. And so I think at this point, I'll just turn things back over to Catherine and our hosts, and we'll jump into questions and answers.
Okay, great. Thank you, Keith and Gary. They're wonderful presentations. I'm going to start with our first question. How likely will a combination trial open soon that will have BRAF, MEK, IPI, anti-PD-1 combined, any combination thereof? How soon do you think we'll have those kind of trials?
I think I'll jump into this one just because I've been involved in some of those discussions pretty actively. The issue that we face with many of these drugs is, well, first off, they're not yet FDA approved. So actually all the drugs just listed in that question and the ones that we've been talking about tonight are not yet FDA approved. Well, certainly not for melanoma. And actually for the BRAF and MEK inhibitors, they're not approved for any cancer just yet. So that actually creates a challenge, because if you have drugs that aren't yet FDA approved, to combine them in clinical trials. It's doable, but there's a lot of, say the least, red tape to get through. And we and others in the academic side and, frankly, in the pharmaceutical companies as well have been pushing very much, actually, to try to accelerate that type of process. So it's pretty clear that we're going to make headway there. And I would predict, based on lots of discussions in this area, that somewhere maybe in the springtime of 2011, we'll see the first combination investigations of a targeted therapy like the ones we've been talking about tonight with those immune therapies, ipilimumab and perhaps PD-1 right behind that. So we're already seeing combinations of targeted therapies come together. So BRAF plus MEK actually is a combination strategy being investigated in an ongoing trial. BRAF or MEK inhibitors combined with inhibitors of the, as I was referred to it before, the PI3 kinase pathway. So those types of strategies are actually ongoing as we speak. But bridging across these different modalities, targeted therapy and immunotherapy, we think there's an enormous amount of promise going in that direction. We just have not been able to actually pull the agents together. Although I'll admit some of these drugs are so young that it's only relatively recently where it's even been possible to conceive of that idea.
Yeah, this is Gary. Yeah, I think these are certainly planned forthcoming studies, and as Keith said, it sometimes takes a little bit of effort to get two companies with two different drugs together to agree to do these types of trials. And but I mean, those discussions are ongoing, and I suspect we'll, as Keith said, see some of these studies open next year, combining especially ipilimumab with a BRAF inhibitor.
Great. Well, we're looking forward to that day.
Yeah.
The next question is regarding AZD6244, which is a MEK inhibitor, and the patient wanted to know if that often caused heart failure, and if it did, can you reduce the dosage if there are heart issues?
I can address. I think I know the patient, actually. I think it's on one of our trials here. We actually have a study of AZD6244 in BRAF mutant melanomas based on screening for what we call a protein called AKT. To answer the question, though, as far as side effects go, this is a very, very unusual side effect of this drug. In fact, I don't think there's ever been a case report of this drug causing heart failure. As far as going back on the drug, I would say it'd be very difficult to do that if there was significant decrease in heart function. And I'm not sure that reducing the dose would make an effect. I'm not even sure the drug's related to the outcome, but clearly, risking again use of the drug in this setting, I think, would probably not be in the patient's best interests. So I think that person would probably be disappointed to hear that at this point. But it does lead issues about other side effects from drugs, and major effect of AZD6244 really is skin rash, and it generally can be treated with topical creams and lotions. From other drugs, the PLX drug, and Keith has lots of experience with that from trials that we're doing here and in Boston, is again rash, but also joint aches and fatigue, which also you see with AZD6244 as well. Fatigue and I guess skin rash would be the major side effects. From the KIT inhibitors, of course, you can get the edema. I mentioned that earlier, such as ankle edema, periorbital edema. But these drugs are generally well tolerated. I think that makes them actually one of the attractions of these types of therapies. They don't have the effects in the bone marrow. They're not myelosuppressive, and most of the side effects are pretty manageable. You want to add anything to this, Keith?
Yeah, no, those points absolutely. And then the other idea that we're building towards, and this goes back to the first question about combination approaches, is that for our really very targeted drugs, the ones that aim narrowly at their target, their molecular target, and this definitely seems to be the case for the BRAF inhibitors, there's emerging evidence, including some published research papers now, that would say that they really don't interfere with immune function whatsoever. So not only not dropping blood counts the way chemotherapy can do, but also not blocking the function of immune cells. And that's a key point, because if we're going to try to combine different approaches, trying to give, let's say, an immune therapy like ipilimumab or the PD-1 antibody with these targeted therapies, it's a critical component that they not interfere with each other. And so So when talking about side effects, we oftentimes first think about rash and diarrhea and so on because we see these things and our patients have to deal with them. But there's also this issue about other molecular effects and how is that going to help us or hurt us in terms of combination approaches.
Well, so far, when working with patients here, we've seen a huge improvement in what patients have to deal with these drugs. So we're real happy to see that change from lower toxicity to an oral drug that also is easy to take and not having to do IV infusions and so on. So
I think the rashes can be problematic for some patients with both these drugs, but the dermatologists now are trying to devise new ways of managing the rashes with different approaches. So I think I recommend that if patients have rashes, they get involved with an academic dermatologist who can help manage that particular side effect of these agents.
Yeah.
Yes, we had a patient who actually found a retired dermatologist who came up with something that was working. So yeah, there's definitely it's worth seeking out and not just dealing with it. It can be pretty,
So these rashes can be pretty significant.
Yes, they can be, especially when they're on your face. Yeah. Okay, so moving on. When compared with IPI, which kind of second-line therapy would you suggest for a BRAF-positive stage 4 melanoma patient?
So I think I'll jump in on that one, and Gary can follow my initial answer. So I gather the question is sort of you try a BRAF-targeted therapy because a BRAF mutation is there, and then if that stops working eventually, what then? So ipilimumab is a therapy that is increasingly available right now as an option. We know the results of a phase 3 trial showing that even as a backup therapy, it can clearly be efficacious. And actually this rather large-scale so-called compassionate use trial is making the drug reasonably readily available to patients in that setting. So the issue then is, well, what else? Well, we really, that goes to a point that Gary brought up earlier, which is we're very much turning our attention right now in the field to trying to understand, okay, well, if we give one of these targeted therapies and it quote-unquote stops working, how is that? How is it that the tumor figures a way to work its way around one of these drugs? Because, mind you, this is happening when we're still giving the therapy. So, this is a topic that has come up in other cancer areas where targeted therapy is frankly a little bit older, at least a few years older than it is in melanoma. And it really does take a very concerted effort, not just amongst clinical researchers, but also amongst laboratory scientists in collaboration, so that we can really try to understand what's making a tumor tick at that point, because we may have a decent understanding of what's driving the tumor at the beginning, but it's at the time that the disease is getting worse that we really need to focus our attention at this point, because in other cancers with targeted therapy, what's been possible is to pinpoint what it is that's driving the tumor at that point, and then use a next targeted therapy to block that. And there's actually even FDA-approved drugs that gone all the way through not just the initial scientific discovery, but then through developing specific drugs for that purpose and actually leading to approval in everyday use. So that's where we're aiming, but we're not there yet. We don't yet know exactly what the mechanism is by which the tumors get their way around. Now, we do have some ideas, and we have some clues from laboratory research, and there's work going on at several major centers, at certainly our 2 centers at Harvard and Sloan Kettering, but beyond that as well. And this is a problem that we really do need to pay attention to. But let me just finish by saying that immune therapies don't seem to depend on the presence or absence of any of these mutations. So it's not only that we think about immune therapy for patients whose tumors don't have a mutation that we can target. No, we still think about them for patients who do have one of these mutations. And so, a drug like ipilimumab in someone whose tumor has a BRAF mutation is something to consider, no question about it. And at least until such time as we come up with an approach as a backup option that is, clearly holds water and just shows us the type of preliminary results we've seen with upfront therapy, I think it's absolutely something that should be considered. And other types of immune therapies that are emerging in clinical trials just the same.
Yeah, I mean, I agree with what Keith is saying there as well. I also would argue that if there is an option for a clinical trial after failing a BRAF inhibitor, I would actually consider that even before ipilimumab as a therapy. There is data actually generated from ipilimumab studies that if you give chemotherapy before ipilimumab, it actually is better than ipilimumab alone. So getting a cytotoxic even before getting ipilimumab may actually be to the advantage of the patient rather than getting ipilimumab without having had chemotherapy at all. But that's one thought. The other thought is that there are novel drug therapies being developed at different centers that have scientific rationale based on developing molecular and cellular biology that do make some sense. For example, we're developing drugs that block several stem cell pathways. One is called Notch, and one is called Sonic Hedgehog. And we've shown that actually blocking the Notch pathway enhances the effect of chemotherapy. So there is an ongoing clinical trial here testing that in patients who have failed the PLX drug or BRAF inhibitors who are chemotherapy naive. We're looking for some other approaches. I'm not saying this is the definitive trial to go into, but I'm saying it's one of many trials that are going on across the country looking at pathways other than BRAF and MEK that may be relevant in melanoma that would be appropriate for patient participation. And I think that's something to think about as people are entertaining other programs after a BRAF targeted drug.
I had a question sort of related to that I've heard among patients, and that's that when the BRAF does fail for them as a therapy, that the disease comes back in a much more aggressive manner. And I wondered is there any truth to that?
You know, obviously, it's for individual patients. It's possible. We've been looking very carefully at that. So you know, as people come off these BRAF targeted drugs, both of the two BRAF inhibitors that I mentioned that have shown clear evidence of promise so far, and we haven't seen that as a general rule. But it's certainly possible that for individual patients, you know, there can be a growth rate at in the weeks or let's say months even following therapy cessation that is concerning or alarming. The reality is that when the tumor is progressing or getting worse, if you will, even while on therapy, so after some number of months of responding, you know, there's already that growth rate, if you will, happening that is, you know, alarming to us because it forces us to have to pursue other treatment options. It's not clear that that trajectory or the rate of that growth actually changes when you then stop therapy, but obviously that's a point we need to study you know, much more carefully. So it's again, it's possible for individual patients, but the general rule has been that if you knew what the growth rate was before treatment ever started, so in the months before BRAF inhibition was ever tried, generally patients seem to go back to that same rate of progression. So it's doesn't seem to be faster or slower.
Okay. Now, if a patient is both CTEP or KIT and BRAF positive, can they try both therapies at the same time?
Well, I'll jump into that quickly, and Gary, I'm sure, has some thoughts too. But we, you know, basically we don't find that combination. So it turns out that I made this comment about NRAS and BRAF that you don't tend to find ever, you know, that both of them are present in the same tumor cell, and so far that's also been the case for BRAF and CTEP. I mean, if there's someone who submitted that question who's already had their tumor analyzed and found that, that would be, you know, extremely important observation because it actually hasn't been reported yet amongst hundreds and hundreds of melanoma tumors that have been genetically analyzed.
So they're usually exclusive of each other.
So those are exclusive of each other. But that raises the point that there's no question, and I should have emphasized this before, that we don't know of a single melanoma that has just one type of mutation. In other words, we've been focusing on the ones for which we've got drugs for tonight's discussion. But we know that there's mutations that happen on top of these other mutations that clearly are part of the puzzle as to how it is that a melanoma can survive, you know, in the setting of a BRAF targeted therapy, for example. And so really the obvious notion is, well, if we can understand more about those other mutations and the pathways in which they operate, could we block those in addition? So combination approaches, combination targeted therapy, if you will, is absolutely the direction the field is moving towards. And really the idea is, well, if we're you know, basing our treatment decisions now on an analysis of a tumor for a BRAF mutation or a CTEP inhibitor, CTEP mutation, you know, why not take it a step further and why not analyze the tumor for more mutations than that, and try to come up with a, let's say, 2-drug strategy for now that's based on 2 mutation events happening at the same time. That sounds simple, but it actually turns out to be complicated operationally to make that happen in a clinical setting, even in a clinical trial setting. But nonetheless, we know we have to do it because the genetic complexity of melanoma goes beyond just any one gene.
Right. Gary, do you have anything to add?
No, I think that's true. I mean, the genes, the mutations are mutually exclusive. We've screened over 200 patients here for KIT mutations, and those who have it, we've never found a concomitant or BRAF mutation. So you either have one or the other. You don't have both, and it biologically makes sense. They're from different parts of the body. They're from different sun, with or without sun exposure. So,
Right.
you really don't find a BRAF mutation with the KIT mutation in the same patient.
Okay. Although KIT isn't exclusively mucosal and acral?
Mucosal, acral, and chronic sun damaged skin.
Right.
Chronic.
Right. Yeah. Very, very rarely in any other the other sort of melanomas arising from the trunk or extremities.
Okay.
I mean, the chronic sun damaged skin, they get something called solar elastosis, which is basically breakdown of the some basal layers of the skin. These are people with the leathery skin. These are the people who've been in their sun a lot.
Tanning salons.
Yeah, chronic, repeated chronic over time sun exposure.
Right.
And that when we say chronic sun damage versus acute sun damage is a different history the patient gives you. And actually, if you look under the microscope, the skin looks chronically damaged with chronic, and it doesn't really look like that when they have melanoma in the setting of a sunburned skin or intermittent, occasional sunburns. It's a really different looking skin. And that's what you see patients from Florida. I'm not disparaging people from Florida, but that's where you see it. Or Australians actually have a high incidence of melanoma, and it's really this one, where they're in the sun all the time. They work outside. They don't put their shirts on. They're chronically exposed to sun, and they get this CTEP mutant melanoma.
And they also have very fair skin.
They're fair skin as well. Yeah.
Okay. The next question is again sort of connected to that. It said Gleevec may be effective in treating a subset of BRAF oncoprotein melanoma. How would you compare this drug with those targeted for BRAF?
I can answer. They're different. You wouldn't use a BRAF inhibitor in a KIT mutant melanoma like you wouldn't use a Gleevec in a BRAF mutant melanoma. The drugs would have no activity. We know that from other studies that c-KIT inhibitors only work even if you have the KIT protein that's insufficient, you have to have the KIT mutation for Gleevec to work. The same thing for BRAF mutant melanoma. You have to have the mutation for the BRAF inhibitors to work. So I don't think you can really compare the two. They're completely different entities going against different oncoproteins that are mutated in different subsets of patients with melanoma.
Okay. And this is what I thought of actually as we were talking along with the recent story in the New York Times about the 2 cousins who, one was randomized to dacarbazine and the other one received the BRAF, and one did well and one did not. And I wondered, and there was continual outrage among our patients as to why we use dacarbazine as the randomized agent when we know it has little effect.
Yeah, well, it raises a very key point, which is, how do we establish efficacy, the good effects of a drug, and then obviously safety as well, to the satisfaction of the authorities that approve drugs. And I guess the quick answer is, well, we don't do that, which is to say that Catherine and Gary and I, none of us are the ones who get to make those decisions. Ultimately, in the U.S. anyway, it's the Food and Drug Administration, and in other countries there's similar regulatory authorities. And what I would say is that if there's a sense in the field, and there is in the melanoma field, absolutely, that the old system isn't working well for us, specifically for this disease, then people need to speak up about that. This is the type of thing where, well, maybe not one phone call is going to change the thinking of the FDA and the government, but it's still the type of thing where the referees of this system, if you will, are the government. And I'm not saying that in all cases randomized trials are a problem or a wrong, but it's clearly the case where there are instances where drugs move forward and they're so clearly better than available options, where there are precedents for this, where didn't require randomized studies, if you will, to lead to FDA approval. The reality is, and this is reading the tea leaves a little bit, when it turns out when it comes to the BRAF targeted drugs, there's a very good chance they actually will get FDA approved without the randomized data. In other words, on the basis of the phase 2 data, which was, those trials were initiated immediately after the phase 1 and executed as quickly as humanly possible, and that evidence will go to the FDA for review for both of the BRAF inhibitors. So in fact, the shortest possible track looks like it may be being taken with these drugs, but along the way, this randomized phase 3 trial was done as well. And arguably, actually, the main argument for why that trial was done in many ways was not necessarily to satisfy the FDA, but the global regulatory authorities, because in other countries, frankly, there's a good deal of conservatism about this issue.
I think Keith stated that fairly well. I'm not going to comment any further on that.
Okay. And then can a BRAF or KIT-negative person respond to any of these targeted therapies? What's the likelihood that they'll be given these therapies in the future once they're out of trial?
We've never seen maybe Keith has, Dr. Flaherty has.
Yeah.
I would honestly say that the mutation is required for a BRAF inhibitor.
Yeah.
The same is absolutely true of a c-KIT inhibitor. They were, as I said in my part of the presentation, 60 patients treated, 59 of them before we had mutational analysis were KIT wild type, and there was no response. The one responder, they didn't know they even had the mutation at the time. They went back and tested the patient for the mutation, and guess what? He had the mutation. So for KIT, absolute, and I would say the same thing's true with BRAF. Maybe
what about
MEK? I would say MEK inhibitors, you have to have the BRAF mutation as well. It's more complicated because we know that the overall response rate is much less with the MEK inhibitor. But as far as I know, at least the preclinical data would absolutely support that. Clinically, there may have been, I don't know of a responder, but my understanding is you have to have a BRAF mutation for that class of drugs as well.
Yeah, there will be, I mean, as Gary already pointed out, there will be drugs that are molecularly targeted drugs. He was referring to some work, that's going on in the Sloan Kettering group, Notch and Hedgehog inhibitors. I apologize for the jargon, but there are some targets, if you will, for which it's not necessarily going to be a mutation that determines sensitivity to those drugs. But for the ones we've talked about tonight, it really does seem to be the case so far that it's a pretty tight lock with having a mutation and being responsive to these therapies.
Yeah, I just kind of base that also on, we had one patient who's been on our forum quite a bit who is BRAF negative and is doing well on the MEK. So
yeah, so that's actually, Gary alluded to the fact that there's a pretty tight connection with BRAF there as well, but you're right, that's not complete. That's the one class of drugs where there have been a handful of responses in patients whose tumors don't have a BRAF mutation, and so it's possible that there's something there that we need to understand more about. Actually, some of that, if based on laboratory evidence, might be people who have NRAS mutations, that mutation that I was referring to.
That's a good point. I mean, they have to have some mutation, an activating mutation.
Right. Well, I mean, and how would they sneak into the trial anyway?
Oh, those trials actually haven't. Many of the MEK inhibitor trials actually have not required BRAF.
They didn't have the. Yeah.
Well, they're trying to explore, where it might work essentially in the early phases of testing,
right.
And so, yeah, that's been the case.
Well, so that's probably good too, since we don't know.
Until we know, I agree. Yeah, absolutely.
Yeah.
But at least with AZD6444, I don't think there was one responder who was BRAF wild type.
That's right. No, it's actually with some of the other MEK inhibitors. There's numerous MEK inhibitors in trials, but yeah, that's right. It's been with other ones.
It may be different with the GSK drug. I don't know, but at least with the published data on the BRAF on the other MEK inhibitor, the 64th word.
Yeah.
That was an absolute requirement.
Right.
For response, for clinical benefit.
Yep.
Okay. Well, we're going to wrap up with our final question, and this one's kind of connected to the dacarbazine question, and that's why is all this taking so long? I mean, our patients are very anxious to have something that works for them. Other cancers seem to have effective agents. Melanoma's sort of been at the bottom. And how can a patient help the process? I mean, besides participating in the trial, who should they lobby to speed up the process to get these drugs through and, be able to get them?
Well, I think both of us should answer this last question. I'm going to start with by saying I would put participating in clinical trials at the top of the list. As you said, besides that, I wouldn't jump over that so quickly. Clinical trial participation in this country continues to be quite low, and it's only through clinical trials that the evidence can never be accumulated to get these drugs to approval. As I alluded to before, as it turns out with the BRAF targeted drugs, they're probably going to have about the shortest time from phase 1 to approval of any targeted therapy ever. So in fact, I would argue there the issue is with melanoma, we just didn't have the targets to go after until relatively recently, and then the drugs needed to be sort of invented, if you will, in the laboratory. So so I'm not sure that we could have accelerated science a whole lot there. And in terms of the regulatory process, as I alluded to before, I think there's definitely room for public discussion. When you're talking about the government, this is basically the entity that's meant to respond to citizens, taxpayers, and so on. And so I think it ultimately is Congress people who are the bosses of the FDA. If there's an argument to be made, that's how to make it.
Yeah, I think Keith covered it there. I think that actually the field of melanoma has moved very, very fast the last year or two. I mean, I've been the chief of this service now a little over 3 years. Which we're just beginning to talk about BRAF as an oncoprotein in cell culture. And I remember having the first conversation with Keith and Paul Chapman. I sat in the conversation when the Plexicon drug was being developed 2 years ago or so. Right. And here we are on the verge of a pivotal randomized registration trial. It may not be the one we all wanted, and clearly there are issues when you have 2 brothers trying to think who's going to get, or 2 cousins get the drug and who gets the chemotherapy. Very painful thing to read about. But we are somewhat restricted by the regulatory mechanisms in place by the government of our country to get drugs approved. And it is moving fast. And I have to say it's moving faster than I've ever seen a drug move forward. And I've been an oncologist here actually for over 20 years. And the development of this drug has exceeded anything I've ever seen before in oncology. And it'll happen, inevitably. But for people with the disease, of course, time is the essence. Minutes really, days or minutes in terms of what's going on in one's life, and we're all very sensitive to that, and we're trying to pressure the process as much as we can. But as oncologists, we're sort of limited in what we can do, but we really do want to move forward as quickly as possible, and hopefully we'll have an answer quite soon on these classes of drugs, and have drugs available for all patients, not only those in patients in clinical trials.
That's a wonderful dream for us. And I think researchers and patients, think alike on this. And I would encourage everybody out there to write to your congressperson and tell them your story. Make sure it's, your congressperson. Tell them you live in their district, and they're all coming up for re-election shortly. And I would tell them, what's going on and all of the hurdles that we have to go through, just to get a drug approved. And a lot of these are for our protection. I totally understand that. But it just seems, we should be using more effective agents or saline water, if we're going to randomize them to nothing. It would seem better. So that would be my opinion.
And I think patient advocacy does make a difference. It's been very effective in the breast cancer field in getting drugs accelerated for approval. And it's been helpful.
Yep.
Well, we'll certainly keep trying. So, well, thank you so much, Gary and Keith, for joining us again for part 2. And we're just really indebted to you for your knowledge and experience with these new drugs. And I hope that, we'll be able to do something again in the near future. I do want to tell everybody that this webinar will be archived, and by 48 hours, we hope, it will be up on our website. And you can just go to melanomapatient.org to find it. If you have any difficulty, just contact us. And if there's nothing else, thank you again.
It's a pleasure.